Hi and welcome to a new episode of your weekly medical TV show on الكرمة TV, White Coat. Addiction and substance abuse disorder is one of the real challenges we're facing right now. It's one of the most important goals in our episode today to confirm that addiction is not a lack of power or will or self-control, but it is a biopsychosocial chronic relapsing brain disease, and today we'll discuss specifically opiate abuse and dependence. The misuse and addiction to opioids include prescription pain relievers, heroin, and synthetic opioids such as fentanyl, for example. Opiate abuse is a serious national crisis that affects public health as well as social and economic welfare. The Centers of Disease Control and Prevention estimate that the total economic burden of prescription opioid misuse alone in the United States of America is about $78.5 billion a year, and that include the cost of health care, loss of productivity, addiction treatment, and criminal justice involvement. Roughly 21 to 29% of patients prescribed opioids for chronic pain misuse them. Between 8 and 12% develop an opioid use disorder. An estimate between 4 to 6% who misuse opioid prescriptions in the beginning, they got a transition to heroin later on. And about 80% of people who used heroin first, they first misused prescription opioids. Today it will be my pleasure and honor to welcome for the first time in White Coat Dr. Tipu to teach us more about this topic and all the possible lines of treatment. For interaction with the program, send in all your questions and concerns regarding our today's topic to our official Facebook page, White Coat ALkarma TV, or if you want to interact with my guests directly, with any questions, you can call the numbers that will be shown on the screen at any time during the episode, and we'll be more than happy to answer all your questions. To keep up with us, please follow us on our Facebook page, White Coat ALkarma TV, or follow us on Instagram, White Coat ALkarma. And to watch our latest episodes, please subscribe to our YouTube channel, الكرمة TV, and please activate the notification bell. أعزائي مشاهدي قنوات الكرمة في كل مكان في العالم، بحب أرحب بيكم في حلقة جديدة من برنامجكم الطبي الأسبوعي على شاشات قنوات الكرمة وايت كوت. الحقيقة النهاردة هنتكلم على مشكلة كبيرة جدا على مستوى العالم، والعالم ابتدى يعني يريكوجنايز المشكلة دي كواحدة من سموها كواحدة من الأزمات الكبيرة جدا على مستوى العالم. بنسميها epidemic crisis، يعني حاجة زي الأوبئة كده اللي بتنتشر، لأنه بدأنا بشكل كبير جدا نلاحظ تزايد الأعداد الناس اللي بتبقى بيتم التعود على مسكنات الألم، وتحديدا على اللي ما يسمى بالأوبيتس أو المورفينات أو بالكودين أو كل مشتقات المورفين بشكل عام. أول ما الناس بتبتدي تستخدمها كمسكنات للألم، وخصوصا بعد عمليات جراحية، بعد أي نوع من أنواع الآلام المزمنة، بيتم التعود عليها بشكل كبير جدا. عشان كده اخترنا أن احنا نناقش في حلقتنا النهاردة مشكلة التعود على مسكنات الألم وإدمان الأوبيتس أو المورفينات بشكل عام. كمان هنتكلم بشكل كبير جدا على الناس اللي بتتطور ده، لأنه بتبقى الستيب اللي بعدها أو الخطوة اللي بعدها بشكل عام هو التعود على الهيروين بشكل كبير جدا. زي ما احنا عارفين انه الهيروين منتشر بشكل كبير جدا في كل دول العالم، وبتبقى دي زي ما بنقول الاسكليت او الخطوة اللي بتلي التعود على او ادمان مسكنات الألم بشكل كبير. جزء مهم من حلقة النهاردة عايزين يعني نخصصها بشكل كبير جدا لفكرة كمان الادمان بشكل عام، لانه يعني احنا عملنا حلقة قبل كده على فكرة ادمان الاوبيتس بشكل عام، ولكن النهارده هنتكلم على ادمان مسكنات الالم والهيروين بشكل خاص. عايزين ناكد على مفهوم مهم جدا، انه فكره الادمان او لما يكون عندنا لا قدر الله حد في البيت ابتدى يدمن، او ابن من ابنائنا ابتدى يدمن، انه دي ملهاش علاقه تماما بفكره نقص الاراده او فكرة انه الاخلاق مش كويسة او عدم القدرة على التحكم في النفس، ولكن عايزين نأكد مع حضراتكم النهاردة على انه الادمان بشكل عام هو مرض زي اي مرض في الدنيا، بيصيب يعني ترانسميترز معينة وسنترز معينة في المخ، فبالتالي لازم نتعامل معاه على انه مرض مزمن زي اي مرض تاني، زي مرض الضغط على سبيل المثال، زي مرض السكر. هو مرض مزمن محتاج دايما علاج ومحتاج دايما مينتننس بشكل كبير جدا. ولكن مش بس فكرة العلاج اللي هو الحبوب، ولكن كمان محتاجين نعمل أنواع تانية من العلاجات زي العلاج النفسي، والاتنين بيمشوا مع بعض على خطين متوازيين عشان نكمل فكرة العلاج بشكل عام. هنتكلم النهاردة مع حضراتكم على يعني الأوبيت إبيديميك تحديدا. هنتكلم كمان على بعض الإحصائيات المهمة جدا اللي تورينا قد إيه المشكلة دي بقت منتشرة. ولكن بشكل عام إنه فوق ال 12% تقريبا من الناس اللي بيتم تعود على مسكنات الألم. وتاني لما بقول مسكنات الألم ما بنقصدش بشكل عام الحاجات اللي هي اوفر ذا كاونتر زي الايبوبروفين او التايلانول او الحاجات دي. بنتكلم على مسكنات الألم اللي لازم تبقى بريسكريبشن زي المورفين زي الكودين زي الهيدروكودون. وهنتكلم برضو على الأسماء المنتشرة كتير زي الفايكودين النوركو اللي هي الحاجات اللي بتبقى براند نيمز. كل ده هنتكلم عليه النهارده. فوق ال 12% من الناس اللي بتبتدي تستخدم الحاجات دي نتيجة لمشاكل الآلام المزمنة أو الكلام ده بيتم التعود. فالنهارده عايزين نناقش ان احنا ما نوصلش للدرجة دي، ازاي بعد عملية جراحية ابتدي اوقف استخدام مسكنات الألم دي بالتدريج خلال اسبوع او 10 ايام بالكتير، عشان جسمنا ما يبنيش حاجة اسمها تولرنس او يبني تعود عليهم. 80% من الناس اللي لقوهم بيدمنوا مادة زي الهيروين في الأصل تم التعود أو وصول لدرجة الهيروين عن طريق أنه تم التعود على مسكنات الألم دي بشكل كبير. تكلفة العلاج في دولة زي الولايات المتحدة عشان نشوف قد إيه الظاهرة دي منتشرة تقريبا فوق ال 78 مليار دولار، يعني تقريبا بالإحصائيات قد الاحتياطي النقدي لدولة زي مصر مرتين بس بنستخدمها عشان نعالج مدمنين الهيروين أو مسكنات الألم هنا بشكل كبير جدا. ده شامل تكلفة العلاج، شامل كمان حاجة اسمها loss of productivity اللي هي فكرة عدم القدرة على الإنتاج، لأنه بتبقى شخص طبعا يعني ما بتقدرش تروح شغلك وتبقى منتج كتير جدا. ويعني آخر الإحصائيات بتقول تقريبا 66% من حالات الطلاق نتيجة بيبقى سبب إدمان، أي شكل من أشكال الإدمان. ولكن برضو دي نقطة محتاجين نقف قدامها بشكل كبير جدا ونحطها في اعتباراتنا انه كل انواع الادمان ممكن يحصل بينها اوفرلاب، فده برضو شيء مهم جدا. بيسعدني ويشرفني ان يكون معايا في حلقة النهاردة واحد من افضل الناس او رواد المجال ده هنا في جنوب كاليفورنيا، دكتور تيبو كان. هيتكلم معانا عن المشكلة دي. كمان هيساعدنا تلقي اسئلة واستفسارات حضراتكم على الهواء في اي وقت. تقدروا تتصلوا بالارقام اللي هتبقى ظاهرة قدام حضراتكم على الشاشة، وهيسعدنا جدا ان احنا نتلقى اسئلة حضراتكم ونجاوب عليها قدر الامكان. نقطة تانية مهمة، زي ما حضراتكم عارفين تقدروا تبعتوا لنا كل اسئلتكم على صفحتنا الرئيسية على الفيسبوك وايت كوت الكرمة تي في. تقدروا تبعتوا اي اسئلة انتوا عايزينها، وبرضه هنبقى سعداء ان احنا نجاوب عليها اثناء الحلقة بشكل كبير. التواصل معنا عن طريق المواقع التواصل الاجتماعي شيء مهم جدا. زي ما حضراتكم شفتوا من شويه صفحتنا الرئيسيه على الفيسبوك وايت كوت الكرمة تي في. تقدروا تبعتوا لنا كمان على صفحتنا على الانستجرام وايت كوت الكرمة. البلاتفورم الثالثه والمهمه جدا هي اليوتيوب الكرمة تي في. تقدروا تعملوا سبسكريبشن، نفعل جرس التنبيهات عشان يوصل حضراتكم اخر الحلقات اللي هي في كل البرامج اللي بتنتجها قنوات الكرمة بشكل عام. اذا حابين تتفرجوا على حلقات فاتت من وايت كوت بشكل خاص، نقدر ندخل على البلاي ليست ونختار برنامج وايت كوت. زي ما حضراتكم شايفين على اليمين هتظهر كل الحلقات اللي عملناها في المواضيع المختلفة، وتقدروا ترجعوا لأي حلقة حضراتكم شايفين إنها يعني هتفيد في بعض الأمراض، وتقدروا ترجعوا لها وتتفرجوا عليها. التواصل عن طريق السوشيال ميديا مهم جدا، شكل كبير من أشكال الدعم، كمان شكل مهم جدا من أشكال التواصل مع البرنامج بشكل خاص. بس افتكرت قبل ما ابتدي أقول إنه دايما عشان الناس كتير بتتكلم على موضوع كورونا، من حلقتين عملنا كل البريكوشنز اللي نقدر ناخدها ونعملها. مفيش أي حاجة اتغيرت في البريكوشنز اللي اتكلمنا عليها. فكرة غسيل إيدين، فكرة الماسك، فكرة ان احنا دايما يعني ما نسيبش زورنا دراي او جاف، دايما فكره الترطيب ال6 فيت هم ما فيش اي حاجه اتغيرت. لما تيجي تتكلم مع شخص خصوصا عنده اي اعراض لازم نسيب فكره ال6 قدم او ما يوازي تقريبا 2 متر، كل ده ما اتغيرش. اللي حاصل بس انه في شويه يعني الاصابه بتتزايد بشكل كبير، والانتقال من انسان لانسان هي دي كانت فكره بزياده الاعداد. برضو باكد على فكره ان احنا بلاش ننساق ورا مواقع التواصل الاجتماعي في فكره يعني فكره ان احنا ناخد معلومات. قدام حضراتكم على الشاشه دلوقتي الفقره اللي اتكلمنا فيها عن كورونا فيروس متاحه على اليوتيوب، وهنحطها تاني او على صفحتنا النهارده وايت كوت الكرمة تي في على الفيسبوك. تقدروا حضراتكم ترجعوا لها بشكل عام، بس هو اللي بيتغير كل مرة هي الأعداد. لو نقدر ندخل على cdc.gov، هو الموقع الرئيسي والرسمي اللي نقدر ناخد منه كل الإحصائيات. مفيش أي حاجة اتغيرت غير زي ما أنا دايما بقول الأرقام. نقدر نستخدم اللغة العربية لو الناس برضو مش عايزة بتقرا باللغه الانجليزيه او ده مش متوفر. نقدر دايما نرجع نختار اللغه من الدايركتوري اللي قدام حضراتكم، ونقدر نقلب كل حاجه العربي، ونقدر نعرف اكتر عن الارقام. طبعا امبارح اعلنا حاله الطوارئ هنا. يعني زي ما انا بقول انه بس هي الفكره يعني حالة الطوارئ هنا في الولايات المتحدة الأمريكية، بس عشان الصورة تبقى واضحة. زي ما أنا بقول هي دورة حياة فيروس، كل حاجة دايما بتجيت ورس قبل ما تجيت بيتر بعد كده. فمتوقع أنه كمان مع وجود هنا تغيرات في الطقس والكلام ده كله، أنه شوية نسبة الانفكشن بين الناس وبعضها ممكن تزيد قبل ما كل حاجة eventually تبقى أحسن بعد كده. كل ده بيعتمد على فكرة أن احنا ناخد دايما البريكوشنز الصح، نبعد عن اماكن التجمعات بشكل كبير، المولات، الحاجات دي قدر الامكان نبقى في البيت. وخصوصا لو في اي اعراض تقدر تتصل بالارقام دايما بتاع الديبارتمنت اوف بابليك هيلث القريب ليك، وتقدر تروح هنا. ده للناس المقيمين في امريكا. مهم جدا انه دايما لو في شك في اي حاجه ان انت تروح وتجيت سكرين قدر الامكان، على اساس انه لو في اي اصابه مبكره نقدر نكتشفها بشكل بدري. سو فار مفيش اي حالات تم، مفيش اي حالات في الاطفال جات ريبورتد، فده شيء كويس جدا. زي ما بنقول المورتاليتي ريت دلوقتي تجاوزت ال 4.5%. على مستوى كبار السن اللي فوق 80 سنه هي دي كانت المشكله، ان المورتاليتي ريت او نسبه الوفيات نتيجه الاصابه في الفيروس تجاوزت ال 15% من اللي اتصابوا، مش من بس توتال السكان. برضو عشان دي تبقى نقطة واضحة، يعني لو في 100 فرد فوق ال 80 سنة أصيبوا بكورونا فيروس، 15% منهم ماتوا. وده طبعا ناتج لأنه الاميونيتي أو الاميون سيستم بشكل عام في الجسم بيقل بالسن. فبس عشان دايما بقول انه الارقام ناخدها من مصادرها الصحيحه cdc.gov. هتشوفوا حضراتكم الخريطه على مستوى العالم، كل دوله فيها كام اصابه. ولكن دايما نرجع لحلقه البرنامج اللي عملناها او الفقره اللي عملناها في البرنامج من حلقتين، هي نفس البريكوشنز او نفس الاجراءات الاحترازيه زي ما بنسميها ما اتغيرتش. بنصلي لكل العالم انه يعني فكره الكورونا دي تبقى افضل في الفترات الجايه ان شاء الله. نرجع تاني لفقرات برنامجنا النهارده. ادمان مسكنات الالم، كمان هنتكلم بسرعه على ادمان الهيروين، طرق العلاج، الادويه اللي ممكن المستخدمه. يلا بينا نبتدي فقرات برنامجنا النهارده من وايت كوت.
قناة الكرمة هي قناة مسيحية لا تهدف للربح المادي 501c3 وجميع التبرعات معفاة من الضرائب ومصدر دعم القناة الوحيد هو تبرعاتكم الشهرية. لذلك اتصل بنا على 714-709-4300 ويمكنك زيارة موقعنا الإلكتروني www.alkarmatv.com أو ارسل لنا على P.O. Box 3610 Seal Beach, California 90740.
So there's a condition called amblyopia, and that's the case in which even with the perfect pair of glasses, the kid does not.
You were born with it, you have it, this is extra.
Pigment is actually important in the pathway from the brain to the eye as the baby is developing in the mother's.
People describe a discomfort, usually in the upper part of the abdomen.
Okay.
Very often it's related to meals, so meals seems to make it.
Good candidates for orthokeratology are generally people who have a risk of increase.
When we talk about the problems of, or the definition of ADD, there are three components.
Okay.
They are, of course.
What's regenerative medicine?
Regenerative medicine is a rather new branch within the whole ecosystem.
Mondays never come. Of course, they never come if you're not ready.
Okay.
If you are not ready to make a change, they don't come. And if you're not ready to make the right change, they will
have
never.
a multitude of symptoms, including memory loss, language issues, thought process issues, behavioral.
So if you have high blood pressure, make sure that you take your doctor's advices very seriously. Basically, there are three things that you need to do. One is control your diet. Number two, do some exercise. And number three, see your physician.
But we need to emphasize that there are children who can be diagnosed with arthritis at very young ages.
So majority of people between 30.
Rheumatoid arthritis is a part of arthritis. Arthritis means inflammation of the joint, mean red, hot, swollen joint.
Okay.
Rheumatoid is one part of arthritis out of hundreds of arthritis.
Okay.
And rheumatoid especially is an autoimmune disease, which means the immune system attacking the body.
هدفنا مش كثرة أقمار صناعية، لكن هو توصيل الكتاب المقدس لكل شبر في الأرض.
أهلا بحضراتكم مرة تانية. فقرتنا الرئيسية النهاردة هنتكلم فيها على إدمان مسكنات الألم والهيروين. هيسعدنا جدا زي ما أنا قلت في الأول إنه حضراتكم تبعتوا لنا على السوشيال ميديا وتقدروا تكلمونا على الأرقام اللي هتبقى قدام حضراتكم على الشاشة. It's my pleasure and honor to welcome for the first time in White Coat Dr. Tipu Khan. Welcome for White Coat for the first time.
Thank you for having me.
It's a huge problem that we're facing now, big challenge, opiate epidemic. But in the beginning, I want to touch up on addiction as a disease because a lot of people think it's just lack of power or lack of morals or it's a lack of self-control. is addiction is a disease like any other kind of diseases?
Yeah, that's a really, really good question. And prior to about 20, 30 years ago, we used to think addiction was mostly a behavioral disease, a lack of willpower, lack of control, and that whole cycle. And so we really pushed the concept of let God and let go, dare to say no to drugs. That was kind of our real push, was a behavioral push to it. What we've learned over the last about 15, 20 years with a lot of scientific studies, including functional MRI scans, which are active brain scans of people who are suffering from an addiction, as well as genetic studies and other types of studies we've done in medicine, is we've found that addiction really is a chronic relapsing remitting brain disease. Okay. So it's similar to having another chronic disease like diabetes or high blood pressure, but it's a central disease in the brain that affects the ability to make appropriate decisions when it comes to a certain pathway in the brain.
Okay. So it is a disease. Is it chronic? Like, what kind of a disease is it?
Yeah, it is. We treat it as a chronic disease. So what we do know is that when these changes happen in the brain, these brain changes happen over a long period of time. Okay. And we have studies called fMRI scans, which we do over time, that look at parts of the brain that are involved. And we find that over time, these can get a little bit better, but nonetheless, the baseline changes are there. So we treat it just like a chronic disease. It's something that you might have times that you do well on, and there's times that it can get worse, it can come back. Okay. So we call it a chronic relapsing remitting disease.
Okay, so it's like diabetes, it's like hypertension, needs treatment, needs maintenance all the time.
And that's a good point you bring up, is not just the treatment, but the maintenance. And that's the part people tend to forget, is they think, oh, I've detoxed, or I've gone through a sobriety period or a treatment and I'm rehabilitated, forgetting that this is a chronic disease of the brain. Maintenance is a critical part in treating this disease.
Okay. Perfect. So سؤالي الأولاني لدكتور كان زي ما قلنا لحضراتكم دايما هنرجع I'll translate every single answer. So زي ما قلنا لحضراتكم فكرة الإدمان مش فكرة إن هو نقص في الإرادة أو نقص في التحكم في النفس أو نقص في أخلاقيات الفرد، ولكن هو زي ما قال دكتور كان هو مرض في المخ ومرض مزمن، فمهم جدا إن احنا دايما يتم علاجه يتم دايما فكرة مش بس العلاج بالأدوية، ولكن جزء منه كمان العلاج النفسي، لأنه الاثنين بيمشوا مع بعض عشان نوصل لفكرة قدر الإمكان يعني إن احنا يتم التعافي بطريقة سليمة من المشكلة دي، لأنه دي نقطة مهمة جدا. So every disease have stages. Do we have stages for addiction?
Yeah, that's another great question. We do have stages in the process of the disease of addiction. And what we are learning is that as time goes on, people go through those stages. So initially we talk about the stages of change, which there's the pre-contemplative, contemplative, different steps in that pathway of the person being able to understand and acknowledge they have a disease. But then even once they come into treatment, then there's the induction phase where we're trying to stabilize them and get them set up. And then there's a stabilization phase where we're actually trying to get them on a stable pathway of treatment. And then finally, like we talked about a little bit earlier, is a maintenance phase, which is the long-term phase. Okay. And that's probably the most critical part of all of this, is going to be that long-term maintenance.
Just to clarify more for our viewers, is it the difference between misuse, abuse, and dependence, or they're all the same?
Yeah, you know, that's an interesting question, because I think oftentimes in layman terms, we interchange those words and we use them amongst each other. But there is a difference between dependence, tolerance, and addiction. So dependence is when the body needs something before having some type of a withdrawal syndrome. So for example, caffeine is a perfect example of that. A lot of us use caffeine on a daily basis. We're dependent on it. We can't function throughout the day. And we actually get tolerant over time, where if we use the same amount of caffeine, it doesn't give us the same effect. But then if we were to stop that caffeine, we would have a withdrawal syndrome, headache, tiredness, not feeling well. Most of us have felt that before at some point. Right. And so in that continuum of that process, people realize that it does shift from dependence to tolerance, finally to what we call a substance use disorder, or in layman's terms, an addiction. And that is when it affects the aspects of your life. It gets you in trouble with law, gets you in trouble with school, unable to hold a job, different factors we use to diagnose that, but it is a continuum.
Okay, perfect. If we get to slide 3 here, if you can explain to us, like this nice slide, what happens in the brain when we get addicted to any substance?
Yeah, great. So let's take a look at slide 3. This is a great illustration of what we're seeing here. So what I like to describe this as is we think about the brain having evolved from the inside out. So the deeper you go into the brain, the older the brain is. So we look at the part of the brain here called the caudate, the putamen, the V-striatum, ventral striatum. These are all parts of what we call the midbrain. This is the area of the brain that's responsible for happiness. And the currency, how that brain works, is in what's called dopamine. It's a neurochemical transmitter.
Okay.
And what happens is when we think back to our original brain, this old pleasure brain, we think back at models like the rat or the mouse.
Okay.
And their entire brain is essentially the midbrain of a human brain. It's that pleasure center. So they're always trying to get things that make them happy and increase dopamine in that brain. Food, pleasure, company, offspring, all these things that increase dopamine. And normally these things might increase dopamine by, say, 10-fold, right? You have a good meal, you get 10 points of dopamine.
Some pleasure.
You see your kids, you get 10 points of dopamine. And that all leads to happiness and pleasure, like you're saying. What happens with substances of abuse is they artificially increase that dopamine by a much higher amount.
Okay.
So instead of getting 10 units of dopamine, you're getting 1,000 or 2,000.
Right.
And what happens is the brain sees that and it becomes accustomed to that, and that causes an affinity pathway where then the brain wants to get more of that. It says, that was really good, I want to have more of that. And that causes what's called reinforcement, where it reinforces, positively reinforces that behavior, to the point where then you might not want to do the things that give you 10 units, like seeing your kids smile. That might not be as important as getting the 100 units. But the important thing here is you realize is the outside of the brain is our executive function. Okay. That's our ability to make decisions, etc. The outside of the brain is not involved in this pathway. This is the inside of the brain. So you and I might say out loud, of course it makes sense. You would want to see your kids over using drugs. But when it comes down to that middle brain, there's no processing there, and you lose that connection. And that's why people will lose their children, lose their family. They won't eat because they're just trying to chase that pleasure.
And the pleasure they get from the substance abuse is much higher than like any other thing. So it's more like priorities, like gets different.
Exactly, and that's a good way to think about it. Is that reinforces that pathway so much so that the outside of the brain, which is again our executive function, the ability to say yes or no, or to think through a problem, we're not able to use that outside of the brain. So I'm not consciously saying I'm going to leave my kid at home and go out and use heroin. It's not a conscious decision. It's a subconscious decision at the middle brain where dopamine is driving so hard that I don't even realize that I'm neglecting my child or my job or my life. I'm just trying to positively reinforce this dopamine pathway.
Perfect. الحقيقة برضو السؤال بالأساسي دايما انتوا يعني بما ان احنا قاعدين نقول انه ده مرض في المخ والكلام ده كله، ايه اللي بيحصل بالظبط في مخنا لما يتم التعود على واحدة من المواد؟ والنهاردة تحديدا هنناقش فكرة الأوبيت. لو بصينا تاني على سلايد 3 هنلاقي الجزء الجراي في السلايد دي اللي هو في النص. بشكل عام دول مركز في المخ مهم جدا بيفرز مادة كيماوية اسمها الدوبامين. الدوبامين دي مادة بتسبب شعور معين بالسعادة وبتخلينا عايزين نحس نفس الشعور. زي ما قال دكتور كان انه يوجوالي الحاجات العادية اللي بنعملها، سواء ان انت بتاكل اكله كويسه او بتقضي وقت كويس مع اسرتك، ده بيفرز عدد وحدات معين من الدوبامين مثلا، وليكن ان احنا نقول 10 وحدات. ولكن لما بيتم التعود على ماده او اي نوع من الادمان بشكل عام، المخ بيبتدي يفرز عدد وحدات كبير جدا من الماده دي. يعني قدرت في بعض المواد بحوالي 1600 وحده من الدوبامين، وبالتالي بشكل كبير جدا المخ بيفضل دايما الحاجات اللي بتديله الدوبامين راش دي، او انه يحس بالدوبامين بشكل كبير جدا. فده بيخلي المخ دايما يتجه للمواد دي اكتر من اي حاجة تانية، وده اللي بيسبب بشكل كبير جدا اهمال الحاجات التانية في حياتنا بشكل عام. When we keep saying opioids, what do we mean by opiates, opioids, painkillers? Just to explain more to our viewers about those stuff.
Yeah, that's a great point. That again falls back down to how we name these drugs and medications. So we use these terms interchangeably. Opiates themselves are natural derived compounds. So morphine, opium, codeine, these are naturally derived from the poppy seed and the poppy plant. Okay. Opioids themselves are chemically derived. So that's fentanyl, etc. So lab-derived compounds. They all act on the same receptor. There's a few different receptors they act on, but the main one we talk about is the opiate mu receptor. Okay. There's also the kappa, the delta, the Orlif. There's a couple other receptors involved. But the big one from the pleasure standpoint and the pain relief standpoint is the mu receptor. And that's the receptor all of these act on. So in general, in layman's term, we tend to use opiates just generally to cover all of them, but there are subtle differences between them.
Okay. So what are the most like famous opiates we used in general to treat like pain?
Yeah. So from a pain standpoint, the ones that most people are going to be familiar with, that they've probably seen or have taken or heard of, or seen family members on, and I'll use the trade names here because that's probably what people are familiar
most
with,
popular, right.
is tramadol, Norcos, Vicodin, OxyContin, oxycodone, Percocet, morphine. Those are the big common ones.
Okay.
And the generics for those are hydrocodone and some other generic names, but these are the common ones you'll see. And if you take a look at the slide that's on the screen, you'll see a list of a lot of the opiates that are out there and opioids that are being used. But the big one, the take-home that most people are going to be familiar with because they see it often, are the Norcos and Vicodins, because that's probably the most commonly prescribed opiate in our current system.
Okay. I have first question here in our social media. He did a spine surgery and he's asking after how long specifically I can get off painkillers so I cannot I cannot form like dependence or tolerance.
That's a great question. Pain management afterwards is a complex topic, and that's something you definitely want to make sure you address with your surgeon or your pain physician, because in some instances, in some surgeries, and some medical conditions, you are going to have pain long term. And an opiate may indeed be the right choice for you, but that's an individualized decision you need to make, understanding the risk and benefits along with your physician. Most spine surgeries, if they're a temporizing fix, then the opiates are there for a period of time, and that can be anywhere from 1 to 8 weeks, and those are usually given with some type of a muscle relaxant as well to help that spine heal. But sometimes there are certain conditions where people are going to have chronic pain, and it might last a while. So the best advice I would have in that situation would be to have an open and frank discussion with your physician and let them know, hey, I really don't want to be on this medication long term. When can I start trying to get off of it? And sometimes it takes a patient-directed and initiated conversation to move that forward, because as physicians, sometimes we fall back and forget about it and we just continue to prescribe it. And that's been our mistake thus far.
Okay, perfect. الحقيقة برضو من الأسئلة اللي دايما مهمة جدا واللي دايما الناس بتسألها لما بنقعد نقول في كل التلفزيونات، ويمكن الرئيس الأمريكي طلع وأعلن إنه في مشكلة مع الأوبيت بشكل عام، وفي مشكلة مع إدمان الأوبيت بشكل عام في دولة هنا زي الولايات المتحدة. انتوا قاعدين تقولوا أوبيتس، يعني إيه أوبيتس؟ يعني بشكل عام كل الأدوية اللي مسكنة للألم اللي بنسميها أدوية الجدول في مصر، واللي بتحتاج بريسكريبشن بشكل كبير جدا. كمان من الحاجات التانية اللي هي بتتطور بعدها فكرة الهيروين. فلو بصينا لسلايد 6 مع حضراتكم، جايبين كل أسماء أو معظم أسماء الأدوية اللي بنعتبرها أوبيت بشكل كبير. أهمهم على الإطلاق هو فكرة الفايكودين، النوركو، اللوراتاب، البيركوسيت، كل دي الأوكسيكونتين، الأوكسيكودون، كل دي الأدوية اللي قدام حضراتكم بنعتبرها، وأشهرهم طبعا على الإطلاق هو الفايكودين. كل الأدوية اللي قدام حضراتكم دي بنعتبرها أوبيتس، بتسبب نسبة كبيرة جدا من التعود. هنوري حضراتكم الإحصائيات بعد دقايق من دلوقتي. لما بناخدها على الفترات الطويلة بتسبب نوع من التعود، لأن جسمنا بيبني حاجة اسمها tolerance. يعني إيه tolerance؟ يعني إنه أنا لو باخد حباية واحدة بتكفي إنها تسكن الألم ل6 ساعات، بعد وقت هتبقى الحباية دي ما بتستمرش أكتر من 2-3 ساعات. بعد شوية وقت هتبقى الحباية الواحدة دي مش كفاية، فابتدي أخد أكتر من حباية، ويبتدي جسمي يبني اللي احنا بنسميه tolerance، ويبني بشكل كبير جدا قدرة على تحمل دوز عالية جدا أو من الأدوية دي بشكل كبير جدا. عايز أقول لحضراتكم كمان بالنسبة للسؤال اللي جه هنا، بيقول إنه هو البير بيقول إنه عامل عملية في العمود الفقري، فقد إيه يقعد على أو قد إيه يستمر إنه ياخد أدوية الألم دي بشكل كبير، لأنه واضح إنه خاف إنه لما إحنا قلنا إنه الأدوية دي بتسبب تعود، زي ما دكتور كان قال إنه تقريبا من أسبوع ل8 أسابيع هي يعني الفترة المثلى، ولكن زي ما هو نصح بشكل كبير جدا إنه حضرتك يعني تناقش ده مع السيرجن بتاعك أو مع الجراح بتاعك، وتشوف قد إيه، لأنه بعض الناس زي ما هو قال بيبقى عندها بعض الأمراض المزمنة فبشكل كبير جدا مهم انه الدسكشن دي تتم ما بين المريض والدكتور، ولو لقينا ان احنا ابتدينا نزود ان احنا ناخد الادويه دي او نقصر المده، يعني بدل ما بناخدها كل ساعات 6 ساعات ابتدينا ناخدها كل 3-4 ساعات، معنى كده انه جسمنا ابتدى يبني حاجه اسمها تولرنس للماده دي، ومهم جدا ان احنا نناقش ده مع الطبيب الخاص بينا. So we have a phone, let's take a phone call from California very quick. معانا مكالمة من كاليفورنيا. بنت الرب اتفضلي حضرتك على الهواء.
الو
اتفضلي يا فندم حضرتك على الهواء. I'll translate.
صباح الخير.
صباح النور يا فندم، اتفضلي حضرتك على الهواء.
أول بنشكركم على البرنامج الحلو دهوت، وأنا للأسف مش دايما بقدر أعرف مواعيده وأتابعه. anyway أنا بتكلم على مشكلة ممكن تكون بعيدة عن الموضوع اللي أنتوا بتتكلموا فيه. المشكلة دي بتخص ابني، هو عنده 18 سنة، هو داخل في موضوع إدمان الإنترنت والسوشيال ميديا لدرجة نظره ضعف ودخل في استجماتيزم وجاله بعد كده سيفير ديبريشن. هو ابني الوحيد فابتدى يقعد لوحده في الأوضة، يعني أنا وأبوه ما بيطلعش يقعد معانا. قطع المدرسة، المفروض يكون السنة دي عمل جراديويت من الهاي سكول دبلومة، ما خدهاش، أديله 4 سنين في البيت. فأنا عايزة أعرف إيه تأثيرات إدمان السوشيال ميديا أو الإنترنت على النظر وعلى العين وعلى البرين نفسه وعلى البيهيفير بتاع الأولاد. يعني هو 18 سنة وقفل على نفسه قفلة كاملة خالص، حتى الكنيسة مش بيروح. فأنا عايزة أعرف يعني إيه اللي ممكن يكون بيحصل، أو إيه العواقب لإدمان الإنترنت أو السوشيال ميديا، أو هل هو ممكن يكون سبب في السيفير ديبريشن اللي جاله ولا لأ. يعني كأطباء أنا حابة أعرف إيه اللي ممكن يكون بيحصل له.
حاضر، خلي حضرتك معانا على الهواء. أنا هخلي دكتور كارني يجاوب حضرتك. She's asking a little bit related topic, internet addiction. She has an 18-year-old son. He's completely isolated on the internet, probably whatever is on the internet all the time. He didn't even graduate his high school. He has been trying to graduate for the last 4 years almost, and then he became depressed. He has like very resistant depression. So she's asking what's the effect of like internet addiction, since we're talking about the addiction topic, on the brain. And does the internet addiction is like any other kind of addiction? We can apply the same principles we talked about.
That's a really great question. I'm so sorry you're having to face this. I can't imagine how hard that is as a parent to watch your child go through this. And you are right. You bring up a couple of really good points. Is any addiction really does involve the same pathway of the brain. Everything from drug addictions, alcohol, caffeine, tobacco, opiates, all the way up to what we call process addiction. So that's internet addiction, gambling, sex addiction, food addiction. These are all also types of what we call process addiction. And what's a little different though about these process addictions is part of it also is housed in what's called the compulsive disorder pathway, where it triggers this obsession where patients want to do some act, play a video game, eat food, whatever it is in this process, and that compulses them to continue in that pathway. So the treatments are very similar, but they are a little different in that the mainstay of treatment, the best thing we can do for your child is to get them into an addiction specialist and an addiction team that can manage both the medical portion, but also what's really, really, really important, especially with adolescents, is behavioral therapy. So the best thing and the best evidence and the data that we have for treatment for process addictions revolves around behavioral interventions. There are some medications that we as physicians will use off-label to see if it'll help, but the best and most data-backed treatment for a situation like this would be things like cognitive behavioral therapy, dialectical behavioral therapy, so psychological interventions to really help train the brain how to cope with different stresses and triggers. So the best advice I'd have in this situation is to treat it like a real disease, another type of an addiction, and get them into an addiction specialist for full spectrum care.
The second part of the question is the depression. So she's asking, is it related to the severe depression does he have now, and should we treat depression with medication?
Good question. It's hard to tell which comes first. We know that up to 25% of people who have an addiction or substance use disorder will also have some co-occurring mental health, depression, anxiety, bipolar, some other mental health disorder. So it's hard to tell which came first. Was it the internet addiction?
It's the egg or the chicken.
Exactly, the chicken or the egg, or was it the depression that came first? But they feed into each other. And so treating both is going to be really, really important. So connecting with a full spectrum addiction team which will usually mean an addiction specialist, a psychologist, and a psychiatrist or an addiction psychiatrist. They will be able to also provide treatment for the depression. If indeed medication is the appropriate treatment for his depression, and that's what the physician recommends in his individual assessment, it probably is the right thing to do. But we want to be careful not to get caught in just the medication part of it. The behavioral intervention is going to be very, very important, especially with the dual diagnosis where you have an addiction and a depression. The behavioral part is going to be probably one of the most critical portions in the solution and the treatment of this disease. But yes, medications, if they're recommended, will be a critical part of treating this.
Okay, perfect. Thank you. الحقيقة زي برضو طبقا لسؤال حضرتك بنعتبر حلقة أو يعني بشكل عام حلقة الوصل بين كل أنواع الإدمان هي فكرة نفس اللي احنا شرحناه عن فكرة الإدمان بشكل عام عن الدوبامين ومادة الدوبامين في البرين، لأنه هي دي نفس الفكرة لكل إدمان أي حاجة. عملنا حلقة قبل كده عن الإدمان الإنترنت تحديدا، يا ريت حضرتك تشوفيها على اليوتيوب. كمان مهم جدا إن احنا نفهم السادة المشاهدين بتوعنا النهاردة إنه الإدمان مش لازم يبقى مادة، الإدمان هو سلوك تكراري يعني بيتكرر بشكل كبير، وأي حاجة بتدي لمخنا نفس البليجر دي أو السعادة دي بنعتبرها شيء مدمن بيطبق عليه حتى يعني نفس قوانين الإدمان بتاع المواد بشكل عام. زي ما دكتور كان قال إنه مهم جدا إن احنا يعني إنه فكرة الديبريشن أو انه الديبريشن مع ادمان الانترنت بشكل عام يعني مش عارف بيبقى عاملين زي البيضه والفرخه مش عارفين مين حصل الاول، فمهم انه الاثنين يتعالجوا مع بعض. زي ما قال دكتور كان كمان انه مهم ان احنا نعمل حاجه اسمها cognitive behavioral therapy، ده نوع من العلاج السلوكي بيبقى مهم جدا، او العلاج النفسي مهم جدا، بيمشي زي ما بنقول ايد مع ايد جنب انواع الميديكيشن اللي ممكن نستخدمها في علاج الدبريشن في حالة زي حالة ابن حضرتك. بالنسبة لمواعيد البرنامج هو كل يوم سبت الساعة 10 بنبتدي بتوقيت كاليفورنيا الساعة 10 زي ما أنا قلت كل يوم سبت. نقطة مهمة تانية، لو حضرتك عايزة ترجعي لحلقة إدمان الإنترنت تقدري دايما تشوفيها على يعني سلسلة حلقات وايت كوت على اليوتيوب، تقدري حضرتك ترجعي لها في أي وقت. ولو في أي أسئلة تانية حضرتك برضو تقدري تتواصلي معنا على صفحتنا الرئيسية على الفيسبوك White Coat ALkarma TV. Statistics always showing us how big is the problem, right? So from a statistical perspective, how likely to get addicted to pain medication in general?
Excuse me, sorry. So that's another great question. What we do know, we don't know exactly clearly the percentage of risk of addiction, although we do know some basic concepts, and that's, I think, the most important part here, is that people who are exposed to a long-acting opiate, so there's different types of opiates. There's short-acting, meaning they last for maybe 2 to 4 hours, and then there's long-acting opiates that can last 6, 8, 12 hours, much longer.
Like oxys specifically,
exactly.
If you want to teach our viewers about
Right, exactly. So a short-acting would be something like Norco or Vicodin, and then a long-acting would be something like OxyContin or long-acting morphine sulfate. So those are what we would think of. Those that are exposed to short-acting, so Norco or Vicodin, like you break your ankle and you're given a few of these for a week or two, we know that there is an increased risk of addiction in people who have certain predispositions. So genetic predispositions, maybe some receptor changes in the brain, they are at higher risk for it. But what we do know is those that are at the highest risk are those that are being exposed to long-acting opiates. We don't really completely understand how, but we know it changes the receptor in the brain itself. And so those exposed to long-actings have a higher risk of addiction, up to even a 25-30% rate of addiction when they're using long-actings. The magic number in medicine we really look at is about 12 weeks. We know that after about 7 to 10 days of an opiate, you're going to be dependent, meaning if you stop it, you might feel a little sick coming off of it. But that doesn't mean an addiction or a substance use disorder. What we're concerned about, though, is when you get to the 12-week mark, that's when the risk really goes up of a substance use disorder or an addiction. So that's kind of the big magic number you'll hear your doctors ask about is, we've gotten to 3 months, what are we doing now? We need to reassess, because after that, your risk goes up.
Okay. I have one question here too. Like 80% usually heroin addicts, they found out to be like, they started on the pain medication like originally. So if we can explain that bridge between pain medication and heroin as well.
That's a beautiful question. I think it's a really important question because unfortunately, a lot of what addiction has been in the past, and it still is today, is a stigma, right? So when we think of an opiate addict, we think of the homeless person on the street with a needle in their arm, just taking our tax money and our tax dollars, right? But that's not what addiction truly is. How did that person get there? How did that person end up where they are? And looking back to it, majority of people started exactly in that situation, is they started from a prescription. So it was us as physicians who actually got them into this pathway. And it's usually for a legitimate cause. It was, I broke my ankle, I broke my back, I had back surgery, as our viewer had earlier. Some legitimate cause. They start on an opiate, but then after time, like we talked about with that dependence, tolerance pathway, their body becomes dependent on it. And then they realize we can't get this prescription anymore from the doctor, because in the medical world, we're being told we're giving too many opiates out, stop giving it out. But we're not told how to safely de-prescribe. And so a lot of physicians, the pendulum swung in one direction where 15 years ago, pain was a vital sign, meaning we treated everyone's pain. We made a point to treat their pain. And opiates were prescribed left and right. And now the pendulum's swinging back in the other direction where it's saying we're prescribing too many opiates, we need to back off of our opiate prescription. What's happening is we're not safely giving patients a way to get off that opiate. So what they're doing is they're saying, I can't get it from my doctor anymore. My doctor said he won't give it to me anymore. I came to see you and you said you can't have him anymore. It's been too long. You don't need it for pain. I can't get off of it because I work 40, 50 hours a week. If I don't take my Norcos, I get sick. Nausea, vomiting, diarrhea. I don't feel good and I have to work and take care of my kids. So I find some on the street. A friend of mine has some extra that he had from when he broke his ankle. He sells them to me. I start buying those and realize I'm spending $30, $40 a day on these prescription pills to help me feel better. And then after a period of time, I realize that this is a lot of money, $30, $40 a day. I can get the same effect from heroin for $10 a day.
Right.
So it's just a natural progression to say that from a cost-benefit perspective, I can't afford $40 a day. Can I save some money? And that's how heroin ends up on their plate.
Get in the picture. Thank you so much. برضو شيء مهم جدا انه حضراتكم تعرفوا فكرة التطور اللي بيحصل مع ادمان المسكنات بشكل عام. زي ما احنا قلنا او زي ما دكتور كان قال كمان انه اللاند مارك اللي دايما بنستخدمها هي 12 اسبوع. بعد 12 اسبوع من استخدام مسكنات الألم وتحديدا مسكنات الجدول، وزي ما هو قال قسمها لنقطتين مهمين جدا، شورت اكتنج ولونج اكتنج. يعني شورت اكتنج يعني المسكنات اللي بتشتغل لفترة قليلة من الوقت، 3-4 ساعات بالكتير، وبعدين بتضطر تاخد تاني، وده تحديدا زي الفايكودين، النوركو، الكلام ده كله. اللونج اكتنج زي ما حضراتكم عرضنا في الاول، فكره الاوكسي كونتين او الام اس كونتين، دول اللونج اكتنج او اللي بيشتغلوا لفتره طويله. والناس اللي بتبقى على النوع ده تحديدا من الادويه لفتره اكتر من 12 اسبوع بتبتدي تبقى عرضة أكتر لفكرة الإدمان. مش بس كده، إنه عادة الإدمان ده بيتطور بشكل كبير جدا، لأنه طبقا للإحصائيات تقريبا لقينا 80% من الناس اللي على هيروين ابتدوا عن طريق فكرة إن هم يدمنوا أو يتم التعود على فكرة مسكنات الألم، والموضوع بيتطور لأنه الهيروين بيبقى أقوى بكتير. وفي نفس الوقت بدل ما انا بجيب الادويه دي من يعني بطريقه مش صح، مش مظبوطه، اقدر اجيب يعني كميه هيروين اقل وتديني نفس التاثير. فابتدى من هنا فكره ادمان الهيروين بشكل عام. فدايما فكره الادمان او التعود على فكره مسكنات الالم بتبقى الكوبري اللي بنعدي بيه لفكره الهيروين، وبالذات في الشباب بشكل كبير جدا. فتحذير مهم جدا انه دايما لما نعمل اي عمليه او يبقى عندنا نوع من الالام المزمنه، بلاش دايما يعني زي ما بنقول ناخد الادويه دي لفترات طويله، وتحديدا اكتر من 12 اسبوع، لانه بعد 12 اسبوع هنبتدي نحس بحاجه اسمها اعراض الانسحاب، وهيبتدي بشكل كبير جدا فرص التعود زي ما قال دكتور كان من 25 ل 30% من الناس دي بتبتدي تتعود على الادويه دي بشكل كبير. فتحذير مهم جدا لكل مشاهدينا اللي بيشوفونا سواء من الكبار او من الشباب، انه ان احنا نبقى على الادويه دي لفتره طويله ممكن يسبب تعود، وزي ما بنقول بيبقى الكوبري اللي بنعدي عليه لفكره الهيروين بشكل كبير. Let's talk about specific populations. In the beginning, let's talk about adolescents specifically. How bad the problem in this kind of like population?
Yeah, that's a great question. Part of what we are concerned about with adolescents is we don't really know how big of a problem it is in that population because they don't report, meaning they don't come to us in clinic, they don't tell us that they have an issue. We have a large study called the NSDA, which is a study we as addiction specialists use to look back at the statistics. And we do know that the rate of adolescent substance use disorder is definitely climbing. And the concerning part is they don't usually present until later, until it's gotten much, much more worse.
If they get like in legal trouble, like
exactly. Yep, they're missing school, they're getting in legal trouble. So by the time they come to us, they're already pretty far into their disorder. So we do know it's really concerning. And we don't have a lot of good FDA-approved medications for treatments of adolescents. And so the mainstay, which is the data and scientific evidence recommends at this point, is really a behavioral-focused therapy, what we call family therapy, involving not just the adolescent, but the family as well in psychological interventions and treatment plans. But there are also medical therapies, which we'll get to in a little bit, the specific medications, but there are medical therapies we can use in adolescents. It's limited, and we have to be careful how we use them in that population.
What we call it the social support network.
Yeah.
Like to strengthen this kind of social support network, so the whole family needs treatment as well.
Right, and that the data and the science and the evidence shows the best treatment outcomes happen when you provide family therapy.
Perfect.
So that's the best thing we can do for our adolescents.
Okay. الحقيقة برضو بالنسبة لإدمان مسكنات الألم أو الهيروين بشكل عام في السن الصغير أو في سن المراهقة بشكل عام، دايما مهم جدا إنه بعض الأدوية بنقدر نستخدمها، ولكن أهم من ده هي العلاج النفسي تحديدا بيبقى مهم جدا في المرحلة دي. زي ما قال دكتور كارن إنه كمان مهم مش بس المتعاطي أو المدمن هو اللي يتعالج، ولكن مهم الدايرة اللي حواليه وتحديدا الأسرة كمان هي تبقى جزء من العلاج ده، ومهم ان هم يبقوا جزء من الجلسات النفسية دي، لأنه دي اللي بنسميها السوشيال سبورت نتورك أو النتورك أو الشبكة الاجتماعية اللي حوالين المتعاطي أو حوالين المدمن بشكل عام، اللي هي كمان لازم تفهم طبيعة المرض ده ويبقى هم جزء من فكرة التعافي أو خطة التعافي بتاع المريض. عشان كده مهم كمان إن هم يبقوا جزء من العلاج النفسي اللي بيبقى حوالين المريض. I'll approach now one of your areas of expertise, which is pregnant women in general. So how big is the problem in pregnant women, and what are the options of treatment like available for them?
Yeah, good question. So opioid use disorder specifically, and just all substance use disorders in pregnancy are also on the rise. So we're having it more and more commonly seen in women. The concerning part really with pregnant women is that you're treating not just one patient, right? You're treating two, because you've got a developing fetus that's being exposed to these chemicals. Most of these drugs and chemicals that the moms are taking are crossing the placenta, and they're causing changes to the developing baby. So it's really important that we engage treatment early. And studies show that if we involve moms in treatment early on, we increase their chance of being successful during treatment. So the biggest take-home point I always like to emphasize with my pregnant patients is the sooner we get you into treatment, the better you're going to do long-term, not just during this pregnancy, but also after pregnancy. And when it comes to opiates specifically, we do not recommend detox or withdrawal of opiates during pregnancy. That's a common question I'll hear is that, can I just wean off my Norco or my Oxy or my heroin? And the answer is no, because opiate withdrawal, as we said earlier, looks like this: nausea, vomiting, diarrhea, anxious, just not feeling well, muscle cramps. The uterus is just a big muscle. So when you withdraw from opiates, your uterus starts contracting. And so you have a higher risk of stillbirth, of losing that baby and that baby dying, or preterm birth. So what we recommend is medication-assisted treatment, and that's either buprenorphine or methadone. But one of these two medications to stabilize you during your pregnancy and afterwards. And the data shows on medication-assisted treatment, women do well. They have they have normal outcomes with their pregnancy. They bond better with their babies. They get to keep their babies. It keeps the family together. So that's what we try to push.
Do we have any data of relapses after like giving birth usually?
We do have data. We do have some studies that have looked at this, and what they have shown is that as long as you maintain your medication-assisted treatment after delivery, you have a low rate of relapse as long as you're stable. And that's a really, really important point, because again, a common question that comes up, rightly so, is now that I've delivered, I just want to get off this so I can be a regular mom again. And what we have is clear scientific data that shows us if you stop your medication-assisted treatment immediately after delivery or shortly after delivery, you relapse. The data is pretty clear on that. So we recommend continuing medication-assisted treatment during your pregnancy and as far out of your postpartum or your after pregnancy period as you can. I recommend at minimum 6 months, don't touch the medication after you deliver. And then if you want to wean off, we can individually discuss this and come up with a plan.
So one of the important messages today in our episode for our pregnant addicts viewers is do not touch the medication for 6 months. Stay on it because the chances of relapse are very high after giving birth.
Yeah, and that's a really good point. And that's a really important message I really want all our viewers to understand, because all of you may interact with patients who are pregnant or know patients who are pregnant, and having treated hundreds and hundreds of these women, what I will tell you is that women who stop their medication during pregnancy or shortly after pregnancy, they have a really, really high risk of failing in treating this disease, and the disease just kind of relapsing. So really, really important point is at least until 6 months or longer in most cases, do not change your medications and follow up with your addiction provider.
Perfect. هي برضو واحدة من الحاجات اللي عايزين نتكلم عنها النهاردة، فكرة إدمان مسكنات الألم أو الهيروين بشكل عام في السيدات وخاصة في الحوامل، لأنه السيدات بشكل عام بيبقى عندهم عرضة لفكرة الآلام المزمنة أكتر من الرجال بشكل كبير جدا. عايز بس أركز النهاردة على فكرة الإدمان في أثناء فترة الحمل، لأنه ده بيبقى مهم جدا. مهم انه المسج النهارده اللي نقولها انه دايما في فرصه حتى لاي حد من الحوامل اللي بيسمعنا عنده مشكله مع فكره الادمان بشكل عام، انه في فرصه انه نتعالج اثناء فتره الحمل، وفي نوعين من الادويه تحديدا لعلاج موضوع الاوبيت ادكشن اللي هو الميثادون والبروبرينورفين، لانه ده مهم جدا ان احنا نقول دايما انه الاثنين دول يعني سهل جدا ان احنا نستخدمهم اثناء فتره الحمل، ولكن المسج المهمه انه بعد الولاده مهم انه يعني يكون البيشنتس او السيده يعني اللي وضعت اوريدي تفضل على الميديكيشنز دول لمده 6 شهور، لانه الريلابس بيبقى مهم، يعني بيبقى نسبه كبيره جدا بعد فكره الوضع بشكل عام. فمهم ان السيدات تكون على الميديكيشنز ده لمده 6 شهور. طبعا السيدات اللي بيعانوا من فكره ادمان مسكنات الالم او الهيروين بشكل عام. الحقيقه يعني هناخد بريك، نرجع نكمل مع حضراتكم فكره ادمان مسكنات الالم والهيروين بشكل عام. هنتكلم اكتر على الاعراض، هنتكلم اكتر على الاحصائيات، احصائيات اكتر تبقى موجوده، واهم من ده كله هنتكلم على فرص العلاج وفرص نجاحه. فناخد بريك ونرجع نكمل مع حضراتكم.
لما بتعطي دايما بهدف، أو عشان تسد احتياج معين لشخص معين أو مكان معين. لما بتعطي في الكرمة مش بتعطي شخص ولا حتى مكان، انت بتشارك في رسالة حب، وبتشارك في نشر السلام، بتشارك في تنفيذ وصية إلهك. ما تتأخرش لما تجيلك فرصة، اعطي بس من قلبك.
نرجع نكمل مع حضراتكم النهارده الفقره الاخيره في برنامجنا النهارده اللي ابتدينا واتكلمنا فيها على فكره إدمان مسكنات الألم وإدمان الهيروين بشكل عام. So you mentioned withdrawal symptoms and signs if we get to the dependence level. What are the symptoms of the withdrawal from opiates in general?
Yeah, the best way I can describe this, and which is what I'd like to show to the viewers, is what it really looks like. And what it really looks like is this: is patients can't sit still, they're anxious, their stomach hurts, they've got goosebumps, they're sweating, vomiting, diarrhea. So it's really a really over anxious state with a lot of gastrointestinal symptoms, vomiting and diarrhea. And that can last for 7 to 10 days. Yeah. And if you can imagine feeling that bad where you can't sit still, you're vomiting, you're restless, you have bone pains and aches everywhere, you've got a runny nose, you can't tolerate that. And that's why it's very typical where people would try to cold turkey or detox themselves with no medication. And they'll get about a day in and they can't feel like that all day long. And the natural thing to do is to then come back to some type of a opiate to help them get through it. Okay. And so that's why people will relapse.
So those can be severe to the point of seizures, for example, or?
Yeah, that's a really...
I have a question here. They're asking about seizure possibility if they went cold turkey.
That's a really good question. We used the old thinking was we thought that opiate withdrawal was not a life-threatening withdrawal. And that was using the lower potency opiates. So the heroin, the oxy, the Norcos, that it wasn't a life-threatening withdrawal. Mostly just feeling bad for a few days, but most people did fine if you could just make it through it. What we're learning now, especially with these higher potency opiates, fentanyl, carfentanil, these oxycontins, these higher potency opiates, they're changing the brain receptors so that people are at risk for more serious issues. And we are seeing seizures in people coming off of opiates now. Again, we're not sure if did they have some underlying seizure issue before that Jeff never got diagnosed and coming off the opiates trigger that, or is it the opiate themselves? We're not sure yet, but we are seeing seizures, especially in people who are on high doses or on fentanyl that are now coming off.
Or it's glazed opiate from the street sometimes, or something else that could be. Okay. Another question here on our social media, 33 years old male has been on Suboxone for 18 months and he's asking you he can get off of it and he think now he's addicted to Suboxone.
And for you who asked that question, thank you for asking that question. That is such a critical concept I'm glad you brought up because it's a very common question. So Suboxone is the trade name for a medication called buprenorphine combined with naloxone. Buprenorphine is the medication we use to treat one of the types of opiate addiction, and it's one of the medicines we use in our arsenal. And being on the buprenorphine is meant to help you prevent you from having use of other opiates. So being on Suboxone should prevent you from using the heroin, the oxys, the whatever, Norcos, whatever you were using. So thinking about addiction as a chronic relapsing remitting disease, if you are doing well on the Suboxone, we don't treat that as an addiction to Suboxone. We treat that as a treatment that's working well. And the analogy I like to use is think about a diabetic. You're a diabetic and you use insulin. If you're using your insulin every single day and your blood sugars are well controlled and your doctor says, hey, great job, your A1C is under 7, you're doing well. That doesn't mean you stop your insulin. Right. That means you continue your insulin and you continue your treatment. And that's how we look at Suboxone, is that if you are doing well on your Suboxone, you're not using other opiates, you're doing good in treating this chronic relapsing remitting disease, we're going to continue treatment. And if you want to long term, we can try to potentially wean you down. But if you stay on it, that doesn't mean you're addicted to it, right? You might be dependent, which is different than addiction. Because you can be dependent on caffeine, you could be dependent on your insulin, but you're not addicted to it.
And plus we look at the negative consequences for it too. If it prevents you from relapses and staying out of trouble, so it's good.
Right,
it's
exactly.
not bad. Okay. الحقيقة برضو شيء مهم جدا ان احنا دايما نسأل ايه هي اعراض انسحاب الاوبيتس بشكل عام او زي ما احنا خلاص بقى حضراتكم عرفتوا لما بنقول اوبيتس يبقى بنتكلم على الهيروين، بنتكلم على البين كيلرز او مسكنات الالم اللي بنسميها مسكنات الجدول. اعراض كتير جدا ممكن يعني الانسان بيحسها مع فكره الانسحاب. اهمهم على الاطلاق هو فكره زي ما قال دكتور كان انه زي ما بنقول كده باللغه الدارجه انه مش قادر يقعد على بعضه، الم في كل عضلات جسمه بشكل عام. بنلاقي طبعا يعني مناخيره نازله بشكل كبير جدا، عرق كتير جدا، بيحس طبعا بكرامبس او تقلصات في بطنه بشكل كبيره جدا. ناس كتير او مدمنين كتير بيعانوا من فكره الاسهال بشكل كبير، طبعا غممان نفس بشكل كبير، ترجيع بشكل كبير. فكل دي اعراض ما بتبقاش يعني لطيفه ان الواحد يحسها. عشان كده احيانا بيضطر يرجع انه يستخدم تاني لانه كل مرة بيحاول إن هو يبطل فيها من نفسه من غير أي مساعدة طبيب، من غير أي مساعدة ميديكيشن. طبعا بيروح للأعراض دي بتبقى يعني مش كويسة أبدا إنه يحسها، وبالتالي إنه بيرجع يستخدم تاني. فده شيء مهم جدا إن احنا نعرف إيه هي أعراض الانسحاب، ولكن إنه دايما في أدوية بنقدر نستخدمها بتقلل أعراض الانسحاب دي بشكل كبير جدا، وبتساعد بشكل كبير جدا في انه المتعاطي ده يبطل، نقلل فكرة اعراض الانسحاب، وانه كمان ما يرجعش يستخدم تاني اللي هي بنسميها فكرة الريلابس. مهم جدا. It's very important to talk about is it genetic? It's like any other kind of disease. Is it genetic? There is a genetic element for it.
Yeah, that's a really, really good question. We do know that there are genetic predispositions to substance use disorders and addiction. And we know that there are certain receptor changes that do go down family lines. And I don't think it takes a physician to know that. Most of us as people can think about that, right? We've got a friend who's got alcoholism and his dad had it and his brother had it. Or we have other friends or family members and you can look back to their lineage and see how it was built up. There was a really good, a couple of really good family studies, but one of the big ones is called the Virginia Twin Study. That was a longitudinal cohort study, meaning they followed twins for a long period of time. And they found that there are definitely some what we call nature versus nurture things. The nurture being what you're exposed to, but there's definitely also a big nature part of it, which is the genetic portion of it. So we do know that addiction is an inheritable disease and it does follow family lines.
Okay. برضو جزء مهم جدا يعني لما نيجي نتكلم على الادكشن او الادمان بشكل عام، فكرة الجزء الجيني. هل هو وراثي؟ هل لو انا عندي اب مثلا مدمن هل انا بالطبيعة لازم اطلع كده؟ زي ما قال دكتور كان انه في ستادي كبيرة جدا اتعملت وتابعوا يعني التوأم متماثل تعرضوا لظروف مختلفة، فلقوا فعلا انه جزء كبير جدا من فكرة الادمان او جزء من فكرة الادمان، بلاش كلمة جزء كبير بس للدقة، هي فكرة وجود الجينات اللي بتساعد على ده بشكل كبير. فطبعا للناس اللي بعتت تسألنا على الكلام ده جزء منه بيبقى ادمان جيني بشكل كبير بالطبيعة يعني. Back to the ASAM, the American Society of Addiction Medicine. Can you walk us through like some statistics, knowing how big is the problem according to the ASAM statistics?
Yeah, great question. I think to start with, I'd love if we can show our viewers slide 17, which is CDC data. So ASAM works very closely with the CDC to help us kind of understand the statistics of opiate addiction.
Okay.
And what we know, though, is currently, as we see in slide 17, which we'll get on there in a minute for the viewers, is the overdose death rates in the country are significantly increasing, and they have been increasing for a few years, going back to the year 2000. So this statistic is continuing to rise, as you can see, as more people are becoming addicted to opiates, more people are dying, and of those overall drug overdose deaths, so that solid line you see on that graph, that first full blue line, that's total overdose deaths, and that's going up. But concordantly, almost on the same slope, is the line below it, which is that dashed line, which is the opiate overdose deaths.
Okay.
And so what that shows is that most of these deaths are actually going to be from opiates now. So it's become so prevalent and so bad that we're now saying, and what ASAM and CDC have both recommended, is that we're now in what's called an epidemic.
Okay.
That the deaths from opiates are so high, we're in an epidemic. The scary part, I think this is the take home, and the bottom line for everyone to understand, is for years, the number one cause of preventable death was motor vehicle accidents, car accidents. That was what killed most people in this country. And recently, unfortunately, opiate overdose has overtaken car accidents as the number one leading cause of unintentional death. That means in this country, you are most likely to die in an unintentional way because of an overdose.
It's even more than Vietnam War, I believe.
Yeah, and that's really scary. And I think we have a slide on that.
Slide 20.
Slide 20, and that's really unfortunate, is in the war in Vietnam, which we all remember, 58,000 people and 58,000 servicemen died, servicemen and women. And to date, just to 2011, 174,000 have died. And that's from 2011. We've had so many more deaths, especially over the last about 4 years.
Since it's trending up, according to the slide.
It's trending up, exactly. Yeah. And I think the other thing people forget in this epidemic is not just the deaths, it's everything else that comes with that. Because we go back to that original case we were talking about. Someone had prescription pills, ended up on heroin. they're putting a needle in their arm. What comes with that needle is everything else that comes with IV drug use, hepatitis C and HIV. And that's the scary part, is hepatitis C and HIV are on the rise again. For the first time in many, many years, both hepatitis C and HIV, which are blood-borne infectious diseases, are climbing because of this opiate epidemic.
الحقيقة برضو سؤال مهم جدا دايما بنسأله، فكرة الإحصائيات بشكل عام زي ما حضراتكم شفتوا في السلايد اللي عرضناها. يا ريت لو نرجع لسلايد 17، الخط الأزرق اللي هو اللي بيبقى اللي فوق في السلايد هو كان فكرة الأوفر دوز في كل الدراجز بشكل عام. ده جزء منه الاوبيتس، ولكن الاوبيتس الجزء اللي تحت اللي هو الخط المقطع شايفين حضراتكم على مدار السنين تقريبا من 2000 ل 2014 فكرة انه الواحد يموت من الاوفر دوز او انه ياخد جرعة زايدة من الهيروين او من يعني البين كيلرز بشكل عام زاد كتير جدا في الفترة الأخيرة، لدرجة ان احنا وصلنا لما نسميه بالإبيديميك أو الكارثة يعني من ده. كمان على يعني في إحصائية لطيفة اتعملت قالت إنه الناس اللي ماتت من الأوفر دوز من الهيروين أو البين كيلرز أكتر من اللي ماتوا في حرب زي حرب فيتنام. زي ما شايفين حضراتكم اللي ماتوا في حرب فيتنام كده على بعضها تقريبا استمرت حوالي 20 سنة، مات حوالي 58 ألف شخص. اللي ماتوا بس من تعاطي جرعات زايدة من الأوبيت لحد سنة 2011 174 ألف شخص. يورينا قد إيه كمية المشكلة اللي بنواجهها بشكل عام. So here in the United States, what we have done so far to address the opiate crisis or opiate epidemic in general?
Yeah, and it's an evolving process. We're still continuing to work on it. But what we're trying to do is attack it from every modality possible. So anytime you deal with an epidemic, or for example, the COVID-19, the pandemic, anytime you have a major issue going on, we want to attack it from as many angles as we can. So some of the things we've done for opiates in our opiate epidemic is we are now asking physicians and prescribing providers to really think long and hard about the use of their opiates. So you have a patient in front of you really reassessing, rather than just refilling that prescription like you've done for the last 5 years, thinking through, is this patient on a correct amount of opiates? Should they even be on an opiate? And that's called what we call safe prescribing. And if they're not, we need to institute safe deprescribing, slowly tapering off the medication. Especially when we get past about 90 milliequivalents, which is a pretty high dose, we really need to think about backing them off slowly and safely.
Okay.
That's one thing we're doing, is safe prescribing, safe deprescribing. We're trying to prevent deaths by educating patients and universally prescribing naloxone, and that's a state mandate in a law now. Anyone with a history of overdose, anyone with a high risk for overdose, or over a certain amount of an opiate needs to be given. Yep, you need to be offered a naloxone prescription. Because we know naloxone, or Narcan as it's known, reverses the opiate overdose and can save people's lives. So trying to reverse the overdose is another part. And then lastly, we have put a lot of money, both from the federal and state standpoint, into boosting addiction specialty training programs. And so we have more addiction specialists that are being trained to go into the community and provide higher level of care. But even aside from the addiction specialists, we're providing more clinical, what's called outpatient-based therapy, where your primary care doc, your family doc, or your internist, or your OB-GYN, or your pediatrician can learn how to use medications like Suboxone and prescribe that to you to get that into your hands.
Perfect. Let's take a phone call from Philadelphia. معنا مكالمة تليفون من فيلادلفيا. سلامة، تفضل حضرتك يا فندم على الهواء. Hello.
Hello.
اتفضل يا فندم حضرتك على الهواء. Hello.
Hello.
اتفضل يا فندم حضرتك على الهواء. يا ريت حضرتك تسمعنا من التليفون وتوطي التلفزيون.
ايوه دكتور. انا باخد
اتفضل حضرتك على الهواء.
ايوه دكتور. انا باخد حباية موترين 800 كل يوم بالليل باد تايم. ده يعتبر تعود؟
Okay. He's asking about Motrin specifically, since we have been saying painkillers. He's taken Motrin 800 every night now. He has to take it. Is that some kind of dependence, he's asking?
Good question. So Motrin is the trade name for ibuprofen. Ibuprofen is not a medication we are concerned about from a addiction or substance use disorder standpoint, but you can have dependence from it, meaning if you were to stop it, you can have a headache if you come off of it. But it's not a drug of abuse that we're concerned about. But the other thing you should think about with high doses of ibuprofen, 800, 600 milligrams, is the potential for it to cause a stomach ulcer. So if you are taking it regularly, you should touch base with your physician to make sure this is the right medication. And if so, you should be taking it with food or milk to help prevent stomach ulcers.
بشكر حضرتك طبعا على اتصالك. زي ما قال دكتور كان، ايبوبروفين او موترين زي ما حضرتك قلت مش من الادويه اللي احنا بيبقى عندنا عليها كونسيرن كبير في فكره التعود او الادمان، ولكن من الناحيه الثانيه اللي قالها دكتور كان انه بيسبب كتير جدا من قرح المعده، فدايما حضرتك تبقى واكل او تشرب لبن بشكل كبير جدا، لانه ده بيساعد في ان احنا نحمي معده حضرتك من القرح. وطبعا كل اللي سمعنا الايبوبروفين والموترين طبعا معروف انه من الحاجات اللي بتسبب قرح المعده، فمهم ناخد شويه بريكوشنز واحنا بناخد الحاجات دي بشكل كبير جدا. For doctor shoppers, because I feel that will be an important message for those people who goes to different doctors to take prescriptions. Do we have from our end anything to tell us how many prescriptions they filled lately or any of that stuff, just to give them an idea what we're looking for from our side?
Yeah, so we have what's called a prescription drug monitoring program, or a PDMP.
So there is one in place.
There is one in place, and it's state specific. So every state has their own monitoring program, but now with federal regulations, all states are essentially being required to have some program. In the state of California, we have what's called the Cures Report. In other states, again, have different versions, but it's still called the PDMP, Prescription Drug Monitoring Program. If we can flip over to slide 23, we can show an example of one.
That would be amazing.
And in California law now, what we require is every 4 months, if you have a patient that's on a chronic opiate, you need to run one of these programs and reports to see what prescriptions they're getting. Okay. What shows up on here are controlled substances, opiates, benzodiazepines, etc. And what you can see if you look on that screen there is a list of physicians they got it from or prescribing providers, what they got, the day supply, when they last picked it up, and this pharmacy they got it from. So we as prescribers should be running this at least every 4 months, and I teach and recommend to my trainees that they should be doing it every time they write a prescription.
Okay.
And this will help us see, did they go to Dr. X, Y, and Z and get the same prescription last week, so we can make sure we safely prescribe.
Perfect. الحقيقة برضو لكل الناس اللي بتروح أو بتبتدي فكرة التعود على إدمان مسكنات الألم، ولما البريسكريبشن ليتس سي خد 30 حبايه من الدكتور ده خلصوا، يروح لدكتور تاني يعني ياخد بريسكريبشن تانيه. مسج او رساله مهمه جدا النهارده من وايت كوت، انه في كل ولايه من الولايات دلوقتي بقى في يعني بنحط في بروجرام معين بنمونيتور بيه كل البريسكريبشنز اللي حضرتك خدتها من كل الدكاتره، على اساس فكره انه لما يتم التعود او الادمان على الحاجات دي، لو حضرتك رحت للدكتور غير اللي انت اخدت من عنده البريسكريبشن، بيبقى عارف حضرتك اخدت كام حبايه من انهي دكتور. دي حاجه بنسميها كيورز ريبورت، وده زي قدام حضراتكم دلوقتي بيورينا حضرتك ايه حاجه اللي خدتها. اي ماده بنسميها من مواد الجدول بشكل عام بتبقى موجوده في الريبورت ده، بيورينا حضرتك اخدت ايه الدواء اللي اخدته، كام حبايه، الدوز اللي اخدتها من انهي فارماسي واخدتها من انهي دكتور. وبالتالي دلوقتي يعني احنا هنا كاطباء في كاليفورنيا او بشكل عام في الولايات المتحده، لانه البروجرام ده فيه زيه في الولايات الثانيه ولكن تحت اسم مختلف، بنعرف بالظبط حضرتك اخدت قد ايه من دكاتره التانيين، وبالتالي ممنوع نهائيا ان احنا ندي لحضرتك بريسكريبشن لو اخدت بريسكريبشن من دكاتره تانيين، unless ان احنا نبتدي نناقش فكره انه بدا يحصل tolerance او بدا يحصل تعود او بدا يحصل ادمان، ونبتدي نعالج البيشنت ده. فمن فضل حضراتكم لكل اللي سامعينا، فكره ان انا اروح لكذا دكتور اخد بريسكريبشنز لادويه الجدول بقت في الفتره الاخيره يعني صعبه جدا، والدكاتره عليها ريستريكشنز كبيره ان هي تدي ميديكيشن للبيشنتس اللي هم زي ما بنقول بنسميهم الدكتور شوبرز او المتسوقين للحاجات دي لدى الدكاتره، فبقى عليها restrictions كبيرة جدا. Time flies, we're almost toward the end. I want 2 messages from you. The first message is to the doctors who prescribe opiates right and left. What do you advise them to do today?
Yeah, great. So when speaking to our colleagues, to our physicians that are out there that are prescribing opiates, the biggest message I would have for you is to individualize your prescription. Think through that patient that's sitting in front of you. Where can they go? What can happen to them, right? We need to think through, are we doing the right thing for this patient? So safe prescribing. If you are going to prescribe, make sure you're checking a cures report, make sure you're giving them some naloxone, check in with them regularly. Don't just write the prescription and send it off to get rid of it. Really provide them appropriate treatment. And on the flip side, if this isn't appropriate for your patient, please do not just stop the prescription. This is how patients cycle into an illegal opiate addiction and end up seeing us in addiction clinic. Please follow the CDC guidelines on safe deprescribing, how to slowly deprescribe at no more than 10% dose reductions a week at the most until you get them to a safe level. And if you need help, please take a look at ASAM, find an addiction specialist close to you, send them to one of us as addiction specialists. We will be happy to help build a safe de-escalation tapering program along with you.
Perfect. الحقيقة رسالة مهمة جدا من دكتور كان النهاردة ومن برنامج وايت كوت للتحديد لكل الأطباء اللي بيشاهدونا. من فضل حضراتكم يا ريت بلاش فكرة ان احنا ندي اوبيتس او بريسكريبشنز عمال على بطال لأي نوع من الألم. زائد لو اكتشفنا انه البيشنت ده عنده نوع من انواع التعود او الادمان، مهم ان احنا نقلل الدوز دي بطريقه صح، مش اقل من 10% من الاسبوع من الدوز الاصليه لحد ما يبتدي يشوف اخصائي ادمان ويبتدي هو يتعامل معاه ويعالجه بشكل عام. Quick questions here on the social media before our second message. She's asking about Neurontin. She's taking 600 TID and she says she can't get off of it. Is that some kind of addiction as well?
Yeah, good question. Gabapentin itself, or Neurontin, is another medication that's difficult to come off of. Coming off of it, you will have a withdrawal syndrome. People will feel sick coming off of it. They can also have risk for seizures coming off of the gabapentin too quickly. So this is another medication that if you've been on Neurontin for a long time, please see your primary care doctor or see an addiction specialist and we will help you safely taper off it. In general, a medication like that, again, we'd expect about a 10% dose reduction every week, maybe 20% every 2 to 3 weeks. So over the course of about 4 to 12 weeks, we can safely taper you off at the fastest. It might take longer. We might only do 10% every month, and it might take a year to do that. But yes, we can definitely help you with that, but don't stop at cold turkey. Work on a taper with your provider.
One last message to the opiate addicts who are watching us today before we get to part 2 on how to help them in treatment.
Right. Last message I would really emphasize for those that are struggling with an opiate use disorder is remember this is not a conscious decision. This is a decision that is being made in a reflexive pattern on the inside of your brain, your old middle brain. So realize that, remember this is a chronic disease and seek medical care. This isn't a failure on your part. This isn't you not being able to just let God and let go or give up that will. This is a chronic relapsing remitting disease. And we are here to help you. Find an addiction specialist close to you. Let us come work with you and help you through this disease for long-term maintenance.
Thank you so much. It was very informative with a promise of part 2 soon.
Thank you.
الحقيقة المسج الأخيرة لدكتور كان لكل اللي بيشاهدونا سؤال بس النيورانتين بسرعة. نيورانتين من المواد اللي بتسبب تعود وإدمان، هنعمل حلقة عنه. حاجة كمان مهمة جدا لكل المدمنين اللي بيشاهدونا وتحديدا للمسكنات الألم والهيروين. دي مش حاجة خاصة بنقص في الإرادة أو الأخلاق أو أي حاجة من دي، ولكن ده مرض مهم دايما ان انت تسأل على مساعدة طبية. بشكر حضراتكم على حسن الاستماع والتفاعل وعلى وعد بحلقة جديدة متميزة من وايت كوت السبت الجاي.